you for accepting my free paper. It's the title Quantitative Perfusion Analysis using a novel contrast enhanced ultrasound to differentiate benign and malignant choroidal tumors. I have no financial disclosure. So before I start, I want to understand why I want to do this novel imaging study. So till now, last 3 decades, we have been using ultrasound to document the tumor size, to do tumor dimensions, but nothing has been changed or nothing has been invented in the field of ultrasound, particularly from the quantitative measurements. What we are doing right now is only about understanding about the reflectivity or echogenicity of the lesions. So if you look at these 3 photographs, they are all A melanotic choroidal lesions. Clinically, they look little bit of different, but the ultrasound, again, all 3 shows smooth dome shape elevated choroidal lesion. So it is very difficult to differentiate one from another just on basis of ultrasound. So with that understanding, we thought let us kind of venture and think whether we can do something novel imaging, particularly in the field of ultrasound using contrast enhanced ultrasonography. So this was a prospective interventional pilot study, the kind of proof of concept of study, which was IRB approved by Institutional Ethics Committee. What we did a classical case of one case of choroidal hemangioma and choroidal melanoma, which was selected for this study. We use a definite dye, which I will be kind of telling you what it is and what we procure it. We injected this dye in a intravenous bolus 1 ml followed by normal saline flush, and the contrast ultrasound was done using the normal ultrasound what we use for routine our ophthalmic clinics, and the video recording was done continuously over 1 minute till the time the dye was injected. The principle of contrast ultrasound, basically it is encapsulated heavy gas bubbles. This is basically the bubbles are made up of perfluoropropane gas, C3F8 gas, which is encased in either lipid or a polymer shell. The diameter of the gas bubbles is close to around 2 to 10 microns, so it is lesser than the size of the RBC. So if the RBC size is 7 to 8 microns, if you assume that this size of these bubbles are lesser than that, they are going to go to each and every tissue, particularly the tumor what we are looking at. And usually this gas gets excreted by the lungs, so there is no any kind of side effects as related to any fluorescein or ICG angiography where there is contraindication related to renal or hepatic circulation. Last thing, what we use is Definity, which is a FDA approved dye, particularly from the cardiology application, what they use for left cardiomyopathy. The principle of contrast enhanced ultrasound basically is the mechanical index of the ultrasound what we usually use when we send any signals from the ultrasound. It's linear signals which are backscattered and taken over by the ultrasound. But in the mechanical index usually of all the ultrasound probes is 0.1 to 0.2 to 0.3. Whenever we increase the mechanical index to 0.2 to 0.3, there is a non-linear resonance which is known as harmonic enhancement, which kinds of sends us signals not only from the signals what we are sent through the ultrasound, but also captured through the tissue microvasculature flow within the choroidal lesions. So this is how the bubble kinds of responds to any ultrasonic burst of 6 megahertz. So image analysis, we kind of located a region of interest within the bulging choroidal lesion, and the mean pixel intensity both pre and post injection frames was calculated. Even the contrast changes with pre and post injection frames were calculated not only from the time of injection but also till 60 seconds post injection frames. To calculate the contrast difference between the area of interest that is within the tumor and the normal choroidal lesion also we kind of compared. Coming to image analysis, the envelope of the ultrasound signals was fitted to the Nakagami probability distribution functions, which basically tells us about the 2 functions. That is, one is the M, which tells about the degree of heterogeneity, and the omega factor, which tells about the average energy of backscattered envelope amplitude. Coming to results, what we could see in both the hemangioma and the melanoma, the contrast difference was a significant increase in the contrast, close to around 10%, whereas it reduced by 4.2% in case of choroidal melanoma. So the higher contrast in choroidal hemangioma indicates that choroidal hemangioma is a much more vascularized tumor as compared to choroidal melanoma. In terms of comparing the tumor region with the normal choroidal lesion, we could see the normal choroidal vascular region was much higher as compared to choroidal tumor region. And we all know from our pathology or from our physiology that choroid is a very highly vascular structure, and that explains why the increased pixel intensity was very high within the normal choroidal lesion. This is just the case what we have done where the contrast ultrasound, we can see pre and post contrast ultrasound, there is increased reflectivity or increased echogenicity within the lesion, and this explains the choroidal hemangioma being having a very thin, large blood vessels with a very high vascular blood flow in comparison choroidal melanoma, where the contrast is much lower as compared to hemangioma, and it explains because of the larger blood vessels, mature blood vessels, and the lower blood flow velocity. The results, again from the Nakagami function, what we could see, the results were much higher in cases of choroidal hemangioma as compared to choroidal melanoma. Limitation, as we understand this is the proof of concept study, so we have included only 2 cases, but over the last 6 months we have included a sample size to close to 10 patients in both the arms, And conclude, I would say, I think this is a preliminary study which will help us to differentiate the benign and malignant choroidal tumors in terms of quantitative measurements using ultrasound. And this information can play a crucial role in tracking the tumor characteristics and also help in predicting treatment outcomes. Thank you.
I'd like to know that when you get the melanoma, that ultrasound, do you think that according to that cell type, the ultrasound picture will be different?
Yes, so in the classical description, what we all know is low angle kappa, where you see high surface reflectivity and the low internal reflectivity. But if there is a tumor necrosis or there is a vitreous hemorrhage within the tumor, then you will have variable reflectivity. Then it will be very difficult to differentiate just on basis of ultrasound.
Dr. Vishal, nice paper, but I want to ask you, it's not the cell pattern which is important. If you see the pattern of vascularity in the choroidal melanoma,
yes,
there is out of 9 vascular pattern, the 3 has a worse or a poor prognosis, okay?
Yes.
Whether you can pick up those in the contrast analysis, that will be important.
So
Secondly, you have compared with choroidal melanoma with hemangioma,
yes,
whether metastasis will be useful. If you see, if you want to show the point, it is the high rise versus the peak time,
yes,
which would give a better in the all the 3 conditions.
Excellent question. So we have included in the recent study 10 cases of melanoma, 10 cases of hemangioma, and 10 cases of choroidal metastasis. So we are currently right now analyzing that results, because at the time of abstract submission, I could only submit the proof of concept of study. But yes, by next year I should have the details of all 3 arms where we are selecting benign and choroidal malignant lesions, limiting not only just to the choroidal but even the retinal circulation, retinoblastoma also we are thinking of using this tissue microvasculature blood flow velocity. Thank you.
Thank you.
Dr. Vishal, one quick question. What is your biggest advantage over the conventional ultrasound? Because on the conventional also we pick up melanomas very well,
Yes.
we pick up hemangiomas very well. They have very characteristic signs. So what is the advantage of doing this and the logistic issues when you compare it to the conventional ultrasound?
Okay, so the conventional ultrasound is just telling you about the reflectivity. It is not telling you about the quantitative. So as you can see, this was a pilot study. We could see there is increased vascularity within the choroidal hemangioma. So it can give a cutoff mark. So that's what we are doing in our next paper in the 10 cases where it shows a cutoff mark of area under the curve, AIOC curve. If it comes below that, we know it is a melanoma. If it goes beyond that, it is a hemangioma. So I think from the ophthalmologist point of view, it might not help, but yes, from the non-paramedical or the optometrist who is doing the contrast ultrasound, if we get that particular value and if they see that, you can make a diagnosis just on basis of your quantitative parameters. So yes, it is kind of evolving study. We want to understand the tissue microvasculature within the tumors, and this is the only way what we can understand. Fluorescein or ICG angiography just tells about the blood flow within the tumor. It doesn't measures the blood flow. So this is the only way which
and
we can
logistic issues?
It's the normal how we do fluorescein angiography, same thing we have to get the dye. So it is nothing unusual what we are doing, and this is FDA approved. People in the cardiology or in the hepatology physicians, they do in and out daily, they do this kind of contrast ultrasound. So there's nothing related to any contraindication. Only contraindication is left to right shunt should not be there. That is what it is FDA in the brochure, it is what is written. Otherwise, it is excreted through the lungs. Within 3 minutes, it gets out of your system. So it is just a normal C3F8 gas, what we daily use in your ophthalmic applications.
Thank you very much.
Vishal, are you aware of a study by Folberg who stated that back-to-back looping of the vascular network and various types of the choroidal vasculature depends on the mortality or prognostic factors?
Yes.
So as you are doing the ultrasound,
Yeah.
Yes, we will look into that.